A very good afternoon, everybody. And this is another session of IC, Unexplained to Explained Decoding Visual Loss. I am Dr. Ankiran Prasad, Chief Instructor. And we welcome all the speakers and all the delegates over here. Please come on over the dais, Dr. Rajesh, Dr. Garima, Dr. Hindu, Dr. Abhijit, Dr. Anita, please. You must be encountered in day-to-day practice to how unexplained visual loss, the vision loss could not be corroborated in any sense to the amount of visual loss. So, any structure abnormality. So, this is a good IC to have some take-home messages and. ऊपर आ जाइए. We have a galaxy of speakers. Dr. Rajesh Shah, who is a trained veterinary surgeon, trained in one of the premier institute of the country, have vast experience of real world scenario in managing veterinary diseases, and very active academically in state and national conferences, have publication in international and peer review journal, and runs Lucknow Eye Center, Lucknow. Another learned speaker is Dr. Indu Pandey, very experienced surgeon, graduate and postgraduate from NICV Medical College, Jabalpur, practicing since last 75 years, have very academically active in all the forum. Dr. Anita, who is an additional professor at IOIGMS, a special interest in the area of neuroophthalmology, who will be decoding the neuroophthalmological cause of the unexplained visual loss. Another, Dr. Garima Chadda, he is a MS ophthalmology and veterinary fellow, have vast experience of 16 years and working in Nagpur. And Dr. Abhijit Chattopadhyay, who is an experienced veterinary surgeon and working at Priyambada, Calcutta. So my topic is how to make history extracting to clue to the diagnosis. So I have no financial disclosure. Unexplained visual loss is one of the challenges faced by the ophthalmologist, and it is defined as a decrease in the best corrected visual acuity, which cannot be explained by underlying pathology of visual pathway or in and out of proportion of identifiable lesion or obvious structural changes in the visual pathway. So before going for the diagnosing as a case of functional visual loss, you must look for the pathology, because once you labeled as a functional visual loss, all investigation ends and treatment strategy and loss to the patient. So you have to carefully look for the any pathology, ocular and non-ocular pathology, before labeling as a functional visual loss to the patient. And there is a, I don't know if there is no definite protocol available in literature how to proceed for this entity. According to Scott and Egan et al., as of 2003, more than half the patient with functional visual turned out to be the organic cause. So we must look for the causes and all. As you know, once patients comes with decreased visual acuity without a countable structural abnormality, following data were collected from the medical record of the patient itself, like demographic information, it plays an important role in localizing the which disease is prevalent in that area, and the pattern of the decreased vision. Initial best corrected visual acuity must be ascertained from the previous data whether patient is having how much vision was there previously going for the visual loss. And duration of the symptom is very important. Time to first visit to the presentation is again important, because it denotes the seriousness of the disease and seriousness of the patient too. And the number of workup done must look for, and because you need not to evaluate go for the another workup, and you can find the clue on that workup only. And an amount of money spent by the patient is important, because financial load should be less to the patient. If you have a review of data, go for the ophthalmic examination. What we have in hand is slit lamp examination, including 90 diopter lens, relative apparent pupillary defect, Goldman apprehension tonometer, ocular mortality examination, including cover, uncover, and Hertzberg's tests to look for the any deviation of the eye. That could be the myopic, and fogging test should be done to rule out whether a patient is having a functional loss or not, and for DOS or for prism diopter test to look for the monofixation syndrome or microtropia. 4 degree of 4 prism diopter test should be done in those cases. So once you have not made conclusion conclusion on this examination, you can subject the patient to the investigation. What we have is array of investigation like OCT, RNFL, macula, fundus fluorescein angiography, visual field, ARG, EOG, VEP, MRI. But the OCT is a mainstay of the treatment nowadays, and you can extract maximum information from the OCT. The cornea lens, vitreous, retina, optic, visual path, all should be okay to have a normal visual, but sometimes we could not find any obstruction or abnormality and examination posing a problem in determining the cause of the decreased vision. Eliciting the cause of the is important before labeling as a functional loss, visual loss, as it helps the process of investigation and further planning of treatment. At the same time, it is also important not to subject unnecessary investigation which have adverse effect on the safety and finances of, of the patient. And the best way to lead the investigation in a proper direction, which way to go for the investigation, is history taking, which is very important. And there is no fixed protocol or guidelines available in literature about how to proceed in the patient of the unexplained vision loss. So triaging is important. It helps in finding the cause, it helps in guiding proper investigation, saving necessary expenditure, and helps in finding out non-arthmetic cause of the decreased vision. So once patient come to your clinic, don't rely on the vision recorded in the other clinics, which may be inaccurate. Always do it by yourself, and don't rely on other vision record. So a patient often comes with decreased vision of the recent origin, because on careful questioning about the duration revealed diminution vision since childhood, but have increased concern recently. So in establishing the diagnosis of amblyopia, and you can have investigation accordingly. Fluctuation or intermittent diminution vision raise suspicion of the OSD. Malignity is one of the main cause of unexplained diminution vision, 5 to 12% of all cases. On the other side, Scott found et al. Found that 53% of patients of functional vision loss found to have concurrent organic pathology. So far as non-retinal pathology include, repeat visual testing is important. Retinoscopy to look for the form first keratoconus, microtropia, cataract mild. If you do the distant direct, you can reveal the information and monitoring. So, and other neurologic causes include the ocular macular dystrophy that can be revealed with the OCT, careful examination. Retinal dystrophy, history of night blindness and ERG can reveal the, in a normal looking fundus, you have a, some kind of CSNV kind of thing. Shallow central, chronic central retinopathy can be seen in OCTFA. And you important thing is you have to have history of any melanoma associated retinopathy, or patient is suffering from the cancer or not. So these two are the finding leads to unexplained visual loss. Past history of head trauma is very important, may lead to damage in the neural pathway. Masquerader of the non-organic visual loss is occult macular dystrophy, cortical visual impairment, and inherited optic neuropathy and autoimmune retinopathy, which can be seen in the cases of any cancer-associated disease. So this is a algorithm. You can, if patient comes to you, recheck VCVA, retroillumination, see of the royal cataract or any media opacity, retinoscopy to rule out keratoconus. If you are not, if a mild visual symptom is there, and changes with the blinking of the eye, dry eye, OSD, which offset can be made. And then you well performed OCT read by the expert. History of head injury is there, then go for the VEP. If history of suspected malingering, just a couple of seconds. Back, back. Uh-huh. Yes. Go for the suspected photophobia, personal history, family history of RP, night blindness, go for the ARG. If no history there, a specific pattern of optic nerve you are seeing or any CNS history, then go for neuroimaging. And if you are non-specific anything, go for VEP. It is normal, then rule out malingering, and if abnormal, rule out old vision loss with the recent awareness, and amblyopia, which I have already explained in our previous slides. Microtropia or monofixation filament, if it's not there, go for neuroimaging. So important decision making, Patient with unexplained visual must be seen in a totality. Presenting complaint must be listened carefully. General condition, you have to take into consideration physical condition, psychological condition, history of accelerated hypertension, cardiac condition, treatment taking, and chronic headache, history of injury, birth history in females, facial conditions. Must look for optic disc pallor or temporal error. Professional history and family history should be taken in totality. So at the last, visit technique is an important tool to give the direction towards the proper investigation and save costing, discomfort to the patient, distress reduction while awaiting reports, decreasing side effect to the procedure. Thanks for your patience hearing. Now I call upon another speaker, Dr. Rajesh. You are in the line. So we will, if you have any question, we will take it at the end of the presentation.
Dr. Rajesh Sahai will be speaking on examination of retina and finding the clue to diminished vision.
Okay, fine. Good afternoon, everyone. It feels very much into our own place and everybody familiar to me. And I feel very much at home, not nervous at all presenting this paper. So this presentation. So let me, sir has given us a very vague idea that what he exactly wants to talk about. So I finally decided I shall talk about all those patients who were referred to me of late. So these were the patients whom I'll be discussing. This is a case-based presentation where all these patients were referred to us for some opinion. And we did a detailed history and a careful examination and somehow could find the diagnosis. And this enabled us to decode vision defect and explain what was unexplained. So my first case is a 38-year-old lady, a housewife. She had a history of sudden painless loss of vision in left eye last month, which recovered in 1 week with some oral medication and drops. Past history of similar vision loss in right eye followed by spontaneous recovery in few days, and she was diabetic of 10 years duration. And on examination, her acuity was 6.6 in both eyes, color vision was normal, blood pressure was 120/70, but this HbA1c was not very good. Bad diabetes control, her CBCSR again was normal. This was her fundus photograph. I could not see any abnormality in the color photo or the red free. Did an OCT. So in the OCT, I found there is some SRF in the right eye, but that does not explain her vision loss, that significant vision loss that she was complaining of. The left eye absolutely was normal. So the probability of the vision loss in past was either retinal migraine due to spasm of retinal artery or amaurosis fugax, as we expect in such cases. Of course, I could rule out optic neuritis and migraine because there was no history of any pain, and the duration of vision loss was not very prolonged. And CSR, of course, I ruled out because of such less fluid and does not recover so fast, quite unlikely to be CSR. So sent this patient for MRI or MRA, what was available there, and that revealed atherosclerotic changes in the, in the common carotid artery. And there was, you can see those red arrows pointing to the thrombus seen in the internal carotid artery. So the diagnosis was easy then. It was TIA or transient monocular vision loss. It was quite common in diabetics and hypertensives. A kind of emergency though, manifold, because there is manifold increase in the incidence of stroke in such patients. So our role is to guide these patients and refer to a neuro or a cardiac physician for care. My second case is a 60-year-old male who complained of defective vision in both eyes. Of course, the left eye was much more affected than the right eye. He has had a cataract surgery in left eye. Was very unhappy following cataract surgery. And he basically complained that his vision deteriorated further after the cataract surgery. So what could be thought of, having poor vision in this patient? This could be amblyopic in that eye. IOL related complications could be there, could be media opacities or some retinal or macular abnormalities, or optic nerve diseases could be the possibilities of poor vision following cataract surgery. So this is a fundus photograph. If you could see that the right eye photograph is not very clear, means some media opacity was there, but the complaint was mainly in the left eye. The media is very clear, and retina looks, either eye, the retina looks myopic. Vision was 636 in the right eye. This is corrected vision, 636 in the right eye. Left eye was 160, not improving by correction. And of course PCL was there, but the refractive error was 12.5 in the unoperated eye, and in the operated it was 8.5. But despite 8.5, the vision wasn't improving. So we went ahead and did there's a detailed summary of the examination, and we found out this. This is then it was obvious after the OCT that this is a case of macular schisis. So macular schisis is also known as myopic traction maculopathy. And of course, prior to OCT, it was very difficult to diagnose, and this results because of rigid ILM, anti-retraction, and progression of posterior staphyloма. And it could be in any layer, the schisis cavities could be in any layer of the retina. And it usually stays stable for many years until it develops macular holes or foveal detachments. Surgical intervention is indicated in progressive vision loss and worsening OCT findings. And we have options of PPV, ILM peeling, and macular buccal in such cases. My case 3 is 40-year-old housewife, obese, hypertensive, hypothyroid, on medication for various disorders, used to taking pills for pain relief occasionally. So why I emphasize all these things? But because we have to talk to the patient and extract the maximum information that sir has been pointing out in his talk earlier. And she complained of defective vision in left eye since 15 days. The fundus photo shows some, some gray, yellow, pale areas in both the eyes, but vision loss was mainly in the left because of the central involvement. So these are serous detachments. So probable diagnosis again was chorioretinitis, weak edge, since no flares or cells were seen, no signs of inflammation, so we could rule out that. Could be CNV or atypical CSR. We did an OCT. We definitely found out some fluid collection under the retina in both the eyes. We did an angio, and it had multiple pinhead hyperfluorescence increasing and pooling in late phases. So definitely it clinches the diagnosis of atypical CSR, and this was because of the chronic use of steroids. She was using Medrol, which was found in her drug box. And this atypical CSR, okay, fine. So let's talk about 2 lines about atypical CSR. This is usually because of increased cortisol levels in the body because of hormonal disorders. And epleneron or subthreshold laser or micropulse laser could be useful in such cases. And this is the 4th case. This will be my last case. This is a 35-year-old male. You can see this fundus. Look at the fundus photograph. Defective night vision. This case was referred to us. Visual acuity 6/6 both eye. Color vision normal. No systemic history. Family history. Sibling having similar night vision problems. Treated with vitamin supplements. The OCT probably you'll not be able to make out much difference in the OCT from a normal in this particular case. But have a look. This is the fundus photograph when we tried to take the periphery. So this was missed by the initial the physician. And I'll show you the comparison of the OCT. This is the OCT of my patient, and this is the normal OCT, and this is advanced RP OCT. So in RP, the OCT changes are much in the outer side of the outer layers of the retina. So it is quite thin in the in my patient as well. So this was a case of retinitis pigmentosa, which was missed by the primary physician, and we all know that it's a heterogeneous group of inherited disorders. Most frequently known cause. Let's not talk about all this. The one thing interesting which I read recently is the Luxturna is a drug which has been tried for RP65, which is a Leber's variant, and it is basically a genetic treatment. And Argus 2 is an implant which is approved for no PL patients. So my time is up. Thank you very much. Thank you.
Now shifting from retina to cornea, Dr. Indu Pandey ma'am will be talking about corneal causes of unexplained visual loss.
So a very good afternoon to one and all. I would like to thank AIOS and Dr. Nagendra sir for being me here. So I would be talking about cornea as a cause of unexplained visual loss. As we all know, cornea is kept in a relatively dehydrated state, and it plays an important role in focusing light onto the retina. So any disruption in the cornea's structure or function relatively or adversely affects the faculty of vision. So few causes like corneal edema, drying of the cornea, degenerations, dystrophies, inflammation, infection, vascularization, and scarring of the cornea, all are responsible for loss of vision. So I would be discussing few cases of mine. So this is a case, a 40-year-old female presented with a recent onset of diminution of vision along with mild pain while the patient was already on oral acyclovir 400 milligram twice a day. So on clinical examination, what I could see was stromal infiltration with inflammation and underlying KPs. There was mild edema also, and the patient was diagnosed as a case of HSV immune stromal keratitis. Now the questions that we need to address is what should be the frequency and how we should taper the steroids, and whether to step up oral acyclovir or to start with the topical, and why did the patient had this recurrence while still on prophylactic antivirals. So the recurrence of the disease is seen in 50% of the cases within 6 weeks of cessation of steroids. Now, once a patient comes to you, what are the features that you should look for which will aid in the diagnosis of HSV immune keratitis? So you should always take a thorough history, ask the patient about the previous episodes, look for the presence of the footprint scars or the ghost figures, look for the vascularization or the ghost vessels. However, corneal sensation is a variable sign. It might be present or might not be present. Now, how do we manage this case? We have to start this patient on oral prednisolone 8 to 10 times per day and then taper gradually on a weekly basis till a dosage of 4 times in a day is achieved. And during all this time, the patient has to be kept on oral acyclovir 400 milligram 5 times in a day. Now, further tapering has to be very slow, and we can go up to alternate day therapy or even twice or thrice in a week. And if you have a patient who has repeated recurrences, then we can even think about switching the patient on a weaker steroids. Now, this is case number 2. The 35-year-old female came with a history of pain, watering, foreign body sensation, and photophobia. The clinical features that I found was that the lesion was in close proximity to the limbus. There was accompanying blood vessel and anterior stromal infiltrate underlying the ulceration, and the lesion was showing central progression. So the diagnosis was HSV marginal keratitis. Now this is because of the active viral disease, and the patients tend to be more symptomatic, and it is more difficult to treat than a central dendritic ulcer. Now this disease, the HSV marginal keratitis, needs to be differentiated from the staphylococcal marginal keratitis, which is an immune reaction, and it shows a special predilection to 2, 4, 8, and 10 o'clock position. There is usual association with the staphylococcal the blepharitis. The lesion shows circumferential spread, and to start with, it is just a stromal infiltration. The epithelium remains intact. And the treatment of staphylococcal marginal keratitis is with steroids, as we all know. But if in a case of viral marginal keratitis, if you prescribe steroids, then it leads to worsening of the condition. So an important DD is staphylococcal marginal keratitis, which always have to be kept in mind. Now, this is a very old patient of mine. He was a 12-year-old boy who would come to me repeatedly for repeated consultation. He had the problem of itching and was diagnosed as a case of VKC. After a few consultations, he started saying that he was not happy with the vision. He was able to see, but the vision was distorted. And even after giving repeated correction with the glasses, he was not comfortable. So what I missed was an underlying keratoconus that had already developed. So the clinical features that we should look for is that the disease typically present in the teens or the early 20s. The patient complains of progressive blurring or distortion of vision, requires frequent change of glasses. There is accompanying photophobia and glare, which is typically worse at night, monoocular diplopia, ocular irritation, and itching. Now, few clinical signs which you can see on torchlight examination are Munson signs, Rigetti's sign, all droplet reflex sign. All these signs are seen once when the disease is well established. Now, on clinical examination, what we see is the presence of ectasia and thinning, the presence of Fleischer's ring. Apical scarring, if present, suggests that the patient has had breaks in the Bowman's membrane. Descemet membrane level scarring suggests previous history of hydrops. Prominent corneal nerves, especially in the periphery, are seen, and we see vogued stria, which are parallel lines seen in the posterior stroma, and they typically disappear once you apply pressure on the globe. So to diagnose a case, the corneal topography is the best modality. In the map that you get, you have to see the symmetry between the upper and the lower half of the map. The symmetry is usually gone. In the central cornea shows more steepness and the thinning of the central cornea. If you are finding these three signs, then your diagnosis of keratoconus is made. Now in keratoconus, how do we treat? In a non-progressive case, we can put the patient on glasses or contact lens, and if the patient is intolerant to contact lenses, then we can go for Intacs, and in advanced cases, PK or DALC is the treatment of choice. In all those progressive cases of keratoconus, collagen cross-linking is the answer. Now, these are few surgical options. Now, this is the most important slide. When and where do you have to suspect keratoconus? So the age of presentation is very typical. It is usually presenting in the teens and early 20s. In all those cases wherein you level the patient as a case of anisometropic amblyopia, you have to first thoroughly check for keratoconus. In all those cases wherein you have high myopic astigmatism, in which the cylindrical power difference between the two eyes is more than 1.5 diopters, these cases are to be screened. Then the scissoring reflex is the first sign that you see on retinoscopy. The presence of Fleischer's ring, which is best seen in cobalt blue filter. It is brown color discoloration present at the base of the cone of the keratoconus. Then topography is the modality of choice for knowing the progression of the disease, and the treatment of choice is cross-linking. So this is my fourth case. The patient in her 50s came with a complaint of early morning decrease of vision, which gradually improved as the day passed. The patient was diagnosed as Fuchs endothelial dystrophy. It is characterized by presence of corneal gutta, which are seen as black spots on direct illumination and give a dewdrop-like appearance on retroillumination. To start with, they are present in the center of the cornea and gradually the cullis, and give a silver beaten metal appearance. In stage 3, wherein you have stromal edema, they will give present as microcyst and bullae, and stage 4 is characterized by subepithelial fibrosis. So the treatment of choice is with the hypertonic saline drops and ointment, dehydration of the cornea, beta blockers, bandage contact lenses when the bullae is ruptured and the patient is in pain. The other options could be DSEC and DMAC in the later stages. Now, what if a patient of Fuchs comes with cataract, then how you should approach such case? Now, the goal is always to protect the corneal endothelium. Pre-operative counseling of the patient has to be done. The patient needs to be explained that patient might require a further corneal surgery. Now, there are few steps that you have to take intraoperatively so as to preserve the corneal function of the patient. Use of the dispersive viscoelastic, removal of the cataract in the bag. Limbal incision should always be made keeping the tunnel short, because you don't want your incision to be on the way of the future DSEC flap. You have to stay away from the endothelium, use less of a power, use less flow rate. Now, supposing you are keeping a flow rate of 40 cc per minute and considering the volume of AC to be 1/4 of a cc, you are turning over the AC 160 times in a minute. So that is quite a turbulence. The normal corneal tissue will rebound back to it, but in Fuchs patients, they don't, and they manifest as corneal edema. So you should always try to keep more of vacuum, use single piece acrylic lenses, very light hydration of the incision needs to be done, and you have to remove completely the visco that you have put. Thank you all.
Now I request Dr. Anita to her presentation on finding clue in optic nerve for unexplained visual loss.
Good afternoon, everyone. I'd like to thank AIOS and Dr. Nagendra sir for including me in this IC. I'll be talking on finding clue in optic nerve for unexplained vision loss. So sometimes ophthalmology makes us feel no less than Sherlock Holmes. So whenever we have a patient with unexplained vision loss, we start from the beginning. We look at the lens, we look at the cornea, the retina, the vitreous, and then finally we look at the disc. Everything else is fine. We look at the disc. Something is really not right, and then that raises a red flag. So there's certain clues which optic nerve can offer, and that is in the form of a disc edema, pallor, or a afferent pupillary defect. But these clues sometimes are very subtle. So there are two things. One, that we miss these clues. Secondly, we see these clues of disc edema, pallor, and we don't know what to do with it. We don't know why it's there. So in neurophthal, the best thing is to start from the very beginning when you are having any doubt, and the history will only give you a lot of clues, as Dr. Nagendra sir has said. You have to find out about the onset, whether it's a rapid onset, whether it's a gradual onset, associated neurological symptoms of jaw claudication, any weakness, any phenomena, like the patient might say that I take bath and my visual symptoms worsen. This might point to a multiple sclerosis. So history taking is very important in a case where you're suspecting optic nerve to be the culprit. History of ATT, linezolid. You have to know what is the latest fever on the block. Is it dengue? Is it chikungunya? Is it COVID? Because all this has bearing on any optic nerve disease, addictions, medical history, hypertension, diabetes. You can have NAION, hereditary optic neuropathies. Find out if only the males are getting, maybe you're having a LHON. So after we're done with the history, we just review again, we check the visual acuity again, see the pupil reaction, color vision, the color desaturation. These are all very simple optic nerve functions. And if we have an afferent pupillary defect, dyschromatopsia, then and a field defect, you're probably dealing with the optic nerve lesion. These are certain ancillary tests which we use, VEP, OCT, RNFL, the ganglion cell count, the fields, the imaging, and Eureka, you have the diagnosis. One of the most important things is missing the RAPD. That is something we miss. We immediately dilate and we're just set to look at the cataract and the retina. So one thing is whenever we have this unexplained vision loss, we should just have a look at the RAPD again. So RAPD, there should be ideal light, the fixation target. Another thing is the reverse RAPD. For example, if you have a traumatic optic neuropathy with the efferent defect, you don't know why the vision is lost. Iris atrophy is the pupil is not reacting, but why the vision is gone. So do you reverse RAPD? Instead of doing the swinging light and seeing from the worse eye from the better eye, put it on the worse eye, check the better eye. So you do a reverse RAPD and you just might get an traumatic optic neuropathy in the eye which you thought just had an efferent defect. So if you do all this properly, you will not be able to miss out a subtle RAPD. Now, retrobulbar neuritis, disc is okay. Posterior ischemic optic neuropathy, disc is fine. Again, the RAPD is going to help us. The color vision, the color desaturation, fields, and of course imaging. But small tests can also help us in finding out the diagnosis. And once we realize, of course, we know that we can find out the causes of the RBN or the posterior ischemic optic neuropathy. Perioperative vision loss, posterior ischemic optic neuropathy should be foremost in our minds. Disc edema. So this is one of the clues which the disc can give us, the optic nerve can give us, that of disc edema. We know the differentials. Sometimes it's not so obvious. We miss the disc edema. If you just look at the disc under the lens, only the nasal part is blurred. Sometimes it's only the superior pole, the inferior pole where the edema is hiding the vessel. So it might be a very subtle disc edema which you are missing. If you look at figure 1A, that is a picture of a Leber's hereditary optic neuropathy with a circumpapillary telangiectasia. It's not very obvious, at least not to me. After a month time, this disc becomes pale, So this is something which we're missing, and we should see that area also. The figure 2A is of a non-arthritic ischemic optic neuropathy. Here the disc edema is quite obvious, but sometimes it's not that obvious. In that case, have a look at the Patton's line, which has concentric retinal folds temporal to the disc. When the disc becomes edematous, these folds come up. These are the Patton's line. They will give us a hint that probably there is some disc edema. Then check the other eye. Check the disc of the other eye. Maybe it's a disc at risk. There's a small CD ratio, and so that corroborates your diagnosis that is it an NAION that I'm dealing with. And these are certain things to look for when we are looking at a disc edema, whether it's a hyperemic disc, look at the margins and nerve fiber swelling, Patton's line, tortuous vessels, all this. Then again, as I said, history, what's happening in the medicine OPD is important. Now, this patient had a sector disc edema, not very obvious, but something was looking wrong. So we went and did the fields and we got an altitudinal field effect. There was history of COVID. After COVID, because of the hypercoagulable state, there can be a NAION. This is again a post-COVID vaccine, optic neuritis both eye. Very subtle disc edema, but the vision was less. The angiogram corroborated the diagnosis of optic neuritis, and there was history of vaccine, the AstraZeneca vaccine. This is another patient who came to us with a vision loss in both the eyes. The left eye, okay, if you see this, just mild nasal blurring of the blood of the disc margin, and the other eye looked normal to us. We did an OCT. So sometimes, the OCT also helps us a lot. It corroborates, the disc is looking suspicious and you see the RNFL thickening. So we can see that the RNFL was thick in two quadrants. But surprisingly, the left eye showed a temporal pallor. In the RNFL, there was RNFL thinning. And when we took history, there was history of 3 weeks back, the patient had only 1 day of fever. And because dengue was prevalent at that time, we got a dengue test and it was positive and the patient was diagnosed with dengue optic neuropathy. And this has bearing on how we treat these patients. Because infective optic neuropathy has to be treated with antibiotics, and we have to control the inflammation also. So I think I'll just go fast. And again, this is a patient with, again, disc edema in one eye. The other disc looked okay, but the GCC showed that there was some problem with the ganglion cell count. Took history. They don't want to give history of spurious alcohol consumption, but here it was given, and then the diagnosis changes. We know the cause of the disc edema, and we treat accordingly, which is very different from how we treat other cases of optic neuropathy. Okay, this is very interesting case. This was a 56-year-old person recently came to us insisting he had a vision loss. The disc was okay, vision was 624, he had some cataract. Finally, I just got fed up and got a field, and there was a right inferior quadrantenopia. And this is the MRI report. There was old infarct with glautic changes in the left occipitotemporoparietal cortex. So the patient might be having a field defect, and his vision is look okay, but basically he's not able to see in a particular field, and he thinks that his vision has gone down. So basically, his complaint was of loss of vision in a particular field. So visual fields, when you have doubts in the optic nerve, do a field, do the color vision. Visual inward potential is also very important. In this patient with a posterior ischemic optic neuropathy, the disc was fine, but it was the P100, the latency of the P100 which was increased, and which told us that there was a problem in the optic nerve. So these are how not to miss the disc edema. Get a stereoscopic picture, look for patterns lines, look for spontaneous venous pulsation. If it's present, there's no disc edema. And of course, take help of OCT and visual field. Another hint that the optic nerve gives us, another clue that the optic nerve gives us is that it becomes pale. And this is a list of reasons why it becomes pale. So pale disc, we again go back, there'll be reduced visual acuity contrast. If it's a bilateral disc pallor or something, then you might not get RAPD, but otherwise you're going to get RAPD. Subtle optic atrophy will be difficult to see. You have a look at the surface capillary net. Then the surface capillary net will be thin. Look at the early finding and look at the red free lights. There'll be loss of peripapillary retinal striations, which looks like rake defects. Partial optic atrophy, temporal pallor, band atrophy might be difficult to see. Total optic atrophy, difficult to miss. This is a bow tie atrophy, which is seen in a optic right. This is a right optic tract or occipital lobe lesion where you can see. Just have a look, there's a bow tie type of a pallor which is seen. This is very easily missed. Again, this is a patient with a nutritional optic neuropathy, temporal pallor. Okay, it could be more subtle than that. And then it's a field which comes to the rescue and you have a central or a centrocecal scotoma. Temporal pallor as a result of nutritional optic neuropathy. The right eye, this is normal NFL, and the other eye shows early changes, early optic atrophic changes of rake defects following focal damage in the red free light. You can see that arrow. Or you can get, this is from the net, ischemic optic neuropathy, you can see wedge defect. So you can get these defects which points towards a optic nerve damage. And in the other eye, we don't see any of that, and that's a optic atrophy case. Sometimes in drugs, for example, anti-epileptic drug like vigabatrin, even in ethambutol, I have seen there's concentric vision field loss, and the pallor comes much later. As somebody has said, disc pallor or the lack of the pallor is an enigma. And you can see this patient who was an anti-epileptic has a concentric field of vision loss, but the disc was not pale. This is another girl, who came to us. She was sent to us from the neurology department. They had seen disc edema. They had given her IVMP. They didn't know why the vision was not improving. And we did the OCT RNFL. It was not that bad except for a slight temporal thinning. But when we did the GCC, just look at the inner retinal layer thinning, the IPL and the GCC, it's all in the red. So we thought, okay, maybe this is a neurodegenerative disorder. There was this article which I saw which said about Alzheimer's disease and said that the GCC gets thin. So this was a sign of a neurodegenerative disorder. We got a conduction, an NCV, nerve conduction test, and it came abnormal. Subsequently, she was diagnosed with a demyelinating disorder and treated accordingly. This is again a pregnant lady who came to us, dikh nahi raha hai, right? But the vision was 6'9", 6'12". So as we ordered a field. Field is such a handy thing to order. We ordered field, we got a bitemporal hemianopia, and she had a macroadenoma. These microadenomas increase in size during pregnancy. So we should take the patient seriously. There might be a field defect, and she might be thinking that, okay, it's a vision loss. Cortical blindness, the pupillary reaction is fine. Everything is fine, but the patient doesn't see. You get a imaging, the CT or the MRI, and you can get lesion in the striate cortex in the occipital lobe. And while here, let us not forget malingering. VP will help us in ruling out the malingering. There's another case of a 27-year-old primey, sister of an ophthalmologist, vision loss. She was having hypertension in pregnancy, vision loss after her discharge. The BP was 180 by 100. I thought cortical blindness because of the BP, but no. The imaging showed a posterior reversible encephalopathy syndrome where there is a vasogenic edema due to the hypertension, and then this resolves. She regained her vision after a week's time. So these are the way we can evaluate a patient who comes with clues in the optic nerve, or when we are suspecting some problem in the optic nerve, we order the field, we get an MRI, OCD, B scan, whole lot of tests, glucose, blood pressure, Doppler, vitamin B12 levels, lab tests, different lab tests. It has to be a very targeted ordering of tests. There's a whole lot of them. And just to conclude, always take, in case of whenever you're suspecting optic nerve lesions, so as to not miss a diagnosis, always take a full neurological and ophthalmic history. Ask specifically about any headaches, hypertension, or diabetes. Other tips are, don't dilate the patient's pupils unless you have seen that there is no RAPD. Pay attention to the perimeter of the disc. Look for the RNFL opacification with obscuration of the retinal vessels overlying the disc margin. Note the color of the disc and any abnormal vasculature. Look for a spontaneous venous pulsation. Look at the other eye. To assess the optic nerve function, check the visual acuity, color vision, contrast sensitivity. Do a visual field test. Look for a large blind spot. Assess the patient's neurological symptoms, system, and cranial nerves. Thank you.
Thank you, Dr. Anita, for your very valuable inputs of unexplained visual loss, which may be the cause of two things I want to highlight that RAPD often miss. Patient comes in OPD with dilated, so it is very important to have. If you have any doubt, call next day and look for the RAPD yourself. Your ophthalmic assistant may not be very trained to look for the subtle RAPD. And next speaker, Dr. Abhijit. Can vitreous be the cause of unexplained visual loss? Dr. Abhijit.
Yeah, thanks, Dr. Nagendra Prasad sir, for giving me the opportunity to talk in this esteemed podium. So my topic is, can vitreous be a cause to unexplained vision loss? So if we see vitreous in a clear media may be creating a problem, which we can see through the diagram, that in the visual axis that may create problem which can cause unexplained vision loss. Along with that, the vitreoretinal interface disorders are there which can create problem also. So we'll try to keep it simple. So common causes for vitreous causing the problems are posterior vitreous detachment, vitreous hemorrhage, intermediate uveitis, and vitreomacular traction and vitreopapillary traction. So posterior vitreous detachment, we get separated posterior vitreous or the Weiss ring in visual axis associated with floaters and flashes. Sometimes we may get retinal breaks, and there may be associated vitreous hemorrhage or even retinal detachment. So this one is the Weiss ring we can see, usually resolves spontaneously, but sometimes may need subtotal vitrectomy. Then this is a very common entity which we miss very regularly, the intermediate uveitis. We get patients even for a few years they are having slowly decreasing vision and they don't get much problem, maybe sometimes topical steroids. So this is Intraocular inflammation mainly focused on vitreous and peripheral retina as per the definition of standardization of uveitis nomenclature. Predominantly painless, floaters, and vision decreasing. There will be cells in vitreous, very mild to moderate AC reaction, snowball opacities, snow banking, and peripheral retinal phlebitis we may get. So this is one of the photos we get in the wide angle photo. The treatment is the mainstay corticosteroids. This is a stepwise, ladder-wise treatment we tell. And then if it is not responding, then we go to the immunosuppressives, then cryotherapy and laser to the peripheral lesions, and of course pars plana vitrectomy. Then there is vitreopapillary retraction. This entity is also very much ignored, in fact, because we may find even disc edema also unexplained. We may advise the patient to undergo MRI and a PEP. But if we do an OCT, we can get it there. In case of decreased vision, we have to go for pars plana vitrectomy. Then there is a vitreoretinal interface disorders that encompasses 3-4 entities like vitreomacular adhesion. They have the grades 1, 2, 3. Then the vitreomacular traction, distorting the fovea, then macular hole, and then macular edema with posterior hilar traction. So how it decreases the vision? There are few of the entities like epiretinal membrane, cystoid macular edema, and pseudocyst, macular schisis, and subretinal fluid, the final common pathway. So imaging we do of the vitreomacular interface with the slit lamp biomicroscopy clinically, then ultrasound, and of course OCT. Treatment protocol for the vitreomacular traction is, or vitreomacular interface disease, is observation mostly, because spontaneously it releases, the traction releases in 30% of cases in grade 1 and 2. And then the surgical removal. Nowadays we are doing this pharmacologic vitreolysis for focal type of lesions with octiplasmin. There are a few other enzymes also which has been used, and papers are there. So there are a few of the surgeries, very small clips. So before surgery, you can see the bad epiretinal membrane is there with the vitreal, the foveal contour flattened. And here, if we see, this is a 27 gauge surgery, and we can see the bad epiretinal membrane. And this is with the forceps, we peeled it off, and wherever we can get the hold, we peeled it off, and you can see over the posterior pole, crossed it, there is some vitreopapillar adhesion also that we have to take care. And this is an old case of blood retinal vein obstruction with laser in the periphery. You can see those areas. And there is another one we can see here. This is also 27 gauge. And this is the same case, I think. This is a 25 gauge vitrectomy, and you can see a bad membrane in the posterior pole. So after doing vitrectomy, we put triamcinolone, and then you can see the triamcinolone attached over the epiretinal membrane. We stained with the billion blue dye also. So after the ERM peeling, we did the ILM peeling, and at the end you can see we stained twice with the brilliant blue to confirm that ILM also peeled here. Basically, peeling the ILM prevents ERM from formation. The recurrence rate is much less. And there is another 27 gauge surgery after the tricot assisted PVD induction. We can see there is a epiretinal membrane with macular hole here. So here we peeled it, and is the inverse flap technique, that is the stained with the brilliant blue dye, and with the phenycyl loop we just took the membranes and put it over the macular hole closing it, and we do the fluid exchange in the normal way. So this is the before and after surgery we can see. So this is the acknowledgement, few slides we took from Dr. Rajesh, and my colleagues Dr. Jonaki and Dr. Shubham Kustri also helped me us. So thank you. And this is one request to all to attend our AIOC conference 2024 in Calcutta. Thank you.
Thank you, Dr. Abhijit. It is vitreous is most often missed entity if you will clinically examine as a unexplained visual loss. So you have very well enumerated the causes and the treatment part of it. Thanks again. Now I request Dr. Garima Chadda, who will be speaking on functional loss and crystallized lens for unexplained visual loss.
A very good afternoon to all. Thank you, Nagin sir and AIOS for giving me this opportunity. So, going from the organic causes to the functional causes now.
नहीं है लोड किया हुआ.
Can we have the slides? Lens changes like this cannot be missed by anyone. But this patient, a 48-year-old farmer female, came with a complaint of blurring of vision in left eye, which she was not happy with. Slit lamp examination of right eye was normal, and left eye showed a dot posterior polar cataract. So the subtle cataract can also be in the center, in the visual axis, can also be a cause of loss of quality of vision. This 15-year-old male boy complaining of gradual blurring of vision in both the eyes. This child was on dialysis weekly for chronic renal failure. He was a case of myopic astigmatism, and patient's parents were actually of the opinion that because of some reasons he is going in depression, and he's trying to find ways out to avoid going to school. But when we did the examination, the oil droplet appearance clinched the diagnosis of lenticonus. There was a scissoring reflex on retinoscopy, and this lenticonus with early capsular cataractous changes was seen. Now coming to the functional visual loss. Functional visual loss or non-organic visual loss by definition is a subnormal vision where no underlying pathology of visual system can be found. Something is out of place here. It's actually a clinical diagnosis, and it may be seen in the continuum from frank malingering to hysteria. The diagnosis relies on the high index of suspicion. The financial burden of evaluation and potential disability-related claims nowadays may be substantial. The aim of this part of the IC is to provide a practical approach to examination of patients with suspected functional visual loss. How to approach a case? In these cases, our aim is to demonstrate that the person has a better vision than alleged. Again, a high index of suspicion where the clinical signs and symptoms do not match. It can be bilateral or unilateral. Subjective and objective tests should be carried out, and it should be carried out swiftly and confidently. There can be some reasons organic also. There can be some cataract. Early cataract can't explain a vision of 660. There can be some disease organic pathology with a superimposed functional component which is making out of proportion loss of vision. Organic causes can also masquerade as functional visual loss, like as Nagin sir has pointed earlier, occult retinal dystrophies, Stargardt dystrophy, CAR, MAR, cortical visual impairment, inherited optic neuropathies. Of occult retinal diseases, maculopathies, paraneoplastic syndrome, vitamin A deficiency, white dot syndromes are to name the few. Whenever we talk about chloroquine maculopathy, the first thing which comes to our mind is bullseye maculopathy. But in early cases, it might not be obviously evident to us. The vision loss in paraneoplastic syndromes is due to the reaction to original cancer that affects the retinal cells, photoreceptors, leading to loss of vision. In cancer-associated retinopathies or melanoma-associated retinopathies, electrophysiological testing is the investigation of choice. And we see different zones and depression right under the center. When we have a case which we suspect as functional visual loss, we want to exclude the subtle causes. Electrophysiology is our friend here. Make sure to order both ERG and VEP together, and this little table is going to guide us. Like if a patient has a normal vision, both ERG and VEP is going to be normal. While if a patient's ERG is abnormal and VEP is normal, that means there is some pathology in the retina. While if the ERG is normal and VEP is abnormal, we expect the pathology to be somewhere in optic nerve or beyond. Examination of a non-organic visual loss case starts as soon as the patient walks inside the room. A truly blind case will walk cautiously, avoiding any furniture or hitting anybody, but a malinger knowingly bumps into them. The test should be performed, all tests, whatever we do, should be performed very smoothly and confidently, and the patient should be taken into confidence. A patient walking into a clinic with sunglasses on is reported as a strong predictor of non-organic vision loss, provided the patient does not have any particular indications such as intense photophobia or acute migraine attack. Finger touching test is a subjective test. Actually, it can be done in patients complaining of profound vision loss, and we suspect a functional case. Because we know finger touching is actually a proprioceptive test. It is not testing the vision. But because we know the physiology better than the patient, we can ask the patient to close the eye or to touch both his fingers together. A malinger usually tries to overshoot. OK and drum elicit optokinetic nystagmus in viewer's eye. And the routine, if a patient even is not able to see anything, ask him to focus towards the OK and drum. It induces smooth pursuit and then refixation saccades. It is helpful in hand motion or worse cases. If we are able to elicit the nystagmus with OK and drum, we establish a vision of at least 20 by 400. Another reflex is mirror reflex. We can distract the patient by holding a conversation with them and use a mirror that is moved across the field of vision. It is difficult for a patient to resist looking at their own reflection and following the moving image. Pupillary reflex, Dr. Anita has very well explained. It is positive in cases with optic neuropathies or severe retinal pathologies. Definitely, you can have normal pupillary reaction in cortical blindness cases. Signature test is again one subjective test, again a feature of proprioception, but a patient who is trying to malinger usually tries to scrib. Stereopsis, we all know, is a feature of binocular vision. Titmus or Randot test can be performed, and it requires a particular minimum level of vision to correlate to the degree of stereopsis. In monocular vision loss, we can blur the seeing eye with a high power convex lens and ask the patient to continue reading. Just make sure the patient's both the eyes are open and he doesn't understand that you are trying to actually assess the bad eye. It can also be done using a combination of plus minus lenses, which is equivalent to plain glass. Based on the principle that the colored lens allow only similar colored light to pass through it, if a patient is made to use red-green glasses and shown this acuity chart, and if he is able to read the entire chart in red and green, that means he has good vision in both the eyes. Usually in malingers, we have a clover leaf type of pattern in perimetry because they deliberately try not to click and they give a falsely negative errors. Prism shift test is an important test in which we close the bad eye and try to induce diplopia in the seeing eye by splitting the pupillary area with a prism. If a patient has no vision in left eye, and while talking to the patient, we induce diplopia in right eye, and gradually we remove the other eye, hand of the other eye, and If the patient is not having no vision in that eye, he won't be able to see any diplopia. He won't be having any diplopia. But if a patient is malingre, the diplopia will still persist. So the management requires an understanding approach. Confrontation is seldom helpful in such cases. It is important to stress to the patient that functional visual loss has a good prognosis, and thereby we are providing a way out, giving the patient the opportunity to recover. So a careful history and examination with a healthy index of suspicion, care of occult visual loss, consider electrodiagnostic testing. In functional visual loss, we demonstrate better eyesight than claimed. I'm sure many of you will be able to read the letter written in this image. It's LIAR. As we say, har jhoot bura nahi hota. Not all liars are bad. We have to give them suggestions, motivation, and encouragement. At times, we need repeated and frequent appointments to build trust and confidence in the patient and suggest potential for improvement. This helps to reduce the doctor shopping and multiple unnecessary testing. Thank you for the attention.
Excellent presentation, Dr. Garima, and very good overview of how to unveil the functional loss and visual loss and all. Thanks. This comes the end of our IC. Any question, any discussion? If any question can be have.
Garima's presentation is also important because we are seeing so many people coming for disability certificates and so that they get help in getting jobs, etc.
Yeah.
So
Nice.
it was very helpful in the.
Yeah,
It was
definitely.
very.
That's ends our IC. Now I thanks all my speaker, London speaker, who came all the way from their place to speak here, and all thanks to all the delegates over present over here who listened our talk. Thanks again. Now I request to come for the photographs and all.
With the photograph.
Eh?